All right, we will start our webinar for today. Okay, Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, salam Malaysia Madani and salam Universiti Watan to our distinguished panelists, Professor Dr. Anjana Silva, Dr. Gregory Chang, Dr. Sabrina Safri, our program advisor, Associate Professor Dr. Ahmad Khaldun bin Ismail, respected clinicians and fellow medical students. I am Safia Ashari.
And I'm Suri.
We are final year medical students currently in emergency medicine posting, and we will be moderators for today's webinar. So, welcome to Season 4, Episode 1 of Clinical Toxinology webinar. Is it relevant for medical students? Organized by Department of Emergency Medicine of Hospital Chancellor Tuan Kumohris. So, for your information, we also collaborated with a few organizations to make this webinar a success, namely Remote Environment Consultation Services, RECS, Malaysia Society of Toxinology, College of Emergency Physician, Special Interest Group in Toxinology, Malaysia Biodiversity Information System, MyBase, and University Science Malaysia National Poison Centre.
Before we begin, we would love to make a few announcements that need to be taken attention of throughout the ceremony. First, please use our Zoom backdrop that has been provided. Feel free to ask any questions through the Zoom Q&A chat box. Questions will be addressed at the end of every case. There will be a feedback form at the end of the webinar to receive your certificate for participation.
All right, to start the session, let's welcome Dr. Nik Azlan bin Nik Muhammad, Head of Module of Emergency Medicine Posting, to give an opening speech. Please welcome.
Assalamualaikum and a very good afternoon to everyone. I'm Dr. Nik Azlan. I'm the head module of medical students in emergency department. So it's been a pleasure to have this webinar, which relates to toxinology. Is it relevant to medical students? As we know that toxinology involves toxins, maybe from wild animals or plants, or maybe from chemicals. So actually, the only place where we can actually safely say that we practice this is in the emergency department. You won't get this in any other attachments. Maybe you'll get some in the medical attachment, but since it's one of the subspecialty in the emergency department, and you can see many cases of inflammation or toxins in the emergency department and also in this country. You can see a lot of different types of inflammation, and this session is actually where we actually can cover that inflammation. So without further delay, I'd like to pass it over to the MC, and very good to have this session, and thank you very much.
All right, thank you to Dr. Nik Azlan for the speech just now.
Next, let's meet our panelists for today. We have a total of 3 panelists. First is Professor Dr. N.K. Anjana Silva, the Chair Professor and Head of Department of Parasitology, Faculty of Medicine and Ill Science, Rajaratha University of Sri Lanka. Dr. Gregory Chang, Senior Consultant Emergency Physician and Toxinologist from Ng Teng Fong General Hospital, Singapore. Dr. Ruth Sabrina Safri, Emergency Physician and Clinical Toxicologist, Emergency and Trauma Department, Hospital Raja Permaisuri Banun, Ipoh, Perak.
So it's my pleasure to welcome you all to today's sessions, where we'll delve into fascinating and critical field of toxinology. So toxinology is a scientific study of toxins, in which the substance produced by living organisms that can harm or even kill other organisms. And these toxins can be either delivered as venom, actively injected through specialized mechanisms like fangs, stingers, or spines, or encountered as poisons, and often through ingestion, inhalation, or even contact with a toxic substance. So this field is particularly important because these natural substances have profound impacts on human health, the environment, as well as medicine. And today, we will explore on clinical toxinology, a vital medical specialty focusing on the treatment of injuries caused by envenomations such as snake bites or even jellyfish stings. And also, it manage poisoning from toxic plants, animals, or even fungi. And this area of study bridges the gap between biology and medicines, addressing the conditions that span emergency care, public health, as well as tropical medicines. So now, let's embark to an insightful journey into how toxinology shapes our understanding of nature, powerful substances, and their implications for human health.
Before we start with our first case, we would like to present our pre-webinar survey findings on student perspectives towards toxinology. A significant 42.1% are unsure about what clinical toxinology is all about. 34.2% of students are already familiar with this field, and 23.7% are not aware of it. This diversity in awareness makes today's session all the more exciting as we aim to bridge the knowledge gap and explore this specialized area in depth. Next, for the awareness of the appropriate safety and health-seeking behavior for toxin injury. Toxin injury is as a medical emergency having a mean awareness score of 4.47, indicating a strong level of awareness among participants. Whereas emergency services for toxin injuries having a mean awareness score of 3.89, showing participants are moderately familiar with this topic. Appropriate healthcare facilities following toxin injury having a mean awareness score of 3.74, which will be one of the topics where we will aim to enhance knowledge further. The role of remove envenomation consultancy service REX having a mean awareness score of 2.97, the lowest among the topics, suggesting a need to raise significant awareness in this area. Next, for the knowledge about appropriate safety and health-seeking behavior for toxin injury, identifying common sign and symptom of a toxin injury, having a mean knowledge score of 3.26, indicating neutral familiarity among participants. Appropriate first aid measures for acute exposure to natural toxin, having a mean knowledge score of 3.05, suggesting room for improved awareness. Sources of natural toxin, 3.32, the highest score, showing moderate awareness. And emergency hotlines and resources for toxin-related disease, 2.58, which is the lowest score, highlighting a significant knowledge gap. Appropriate antivenoms for treating envenomation in Malaysia, 2.63, showing low awareness in this critical area. Next, for confidence in providing instruction or information for toxin injury, how to identify potential toxin injury having a mean confidence score of 2.82, indicating participants are approaching moderate confidence. How to administer appropriate first aid for toxin-related injury, 2.53, the lowest score, highlighting a significant area for improvement. Informing emergency procedure in cases of suspected toxin exposure, mean confidence score 2.82, which is similar to the first topic, showing a moderate level of confidence. Importance history detail to obtain following a toxin injury. Mean confidence score 3.03, the highest score, suggesting moderate confidence in this area. Where one should be brought after a toxin injury, mean confidence score 3.08, reflecting the highest confidence level among all topics.
All right, so without further ado, let's dive into the highlighted part of today's agenda, which is case discussions. So for the session, we will invite the panelists for discussion, followed by a short Q&A sessions. And for the audience, you can drop your questions in the Q&A box down below during each case presentation, and we will address your questions directly to the panelists. So now let's begin with the first case. So for case one, we have a 26 years old male with no known medical illness presented to emergency department with right lower limb pain for 2 days. He noted a redness and pain over the right shin upon waking up from sleep with a pain score of 5/10 in throbbing in nature. And the pain also radiates to the knee. And however, he is unsure of the cause. He was also unable to act bearing over the right lower limb, and he required a walking stick to ambulate around. And patient claimed that there is a pus discharge over the affected area. There is also feverish for 1 day, and patient felt chills, however, no paracetamol taken, and patient able to tolerate orally well. Otherwise, there's no UTI symptoms, no GI losses or abdominal pain, no history of fault or even trauma, and no history of syncope, loss of consciousness, or even fainting. And he denied chest pain and shortness of breath or even any jungle or river activities. So from now on, I open for the panelists to discuss on this case based on the history first.
Can I start? Right. So basically, for this case, if we see, basically, the patient is young, 26-year-old male with no known comorbid, no known medical illness, right? So, this is the chief complaint of the patient. And then, what we need to know in the history of presenting illness is that, we need to know whether the patient has family history of diabetes before, because all that we know, patient might have um, type 1 diabetes that we do not know. And then basically more on the history of presenting illness. I mean, other things that the patient can tell us with regards before the patient is having the lower limb pain. Whether the patient has been bitten by something, some animals, whether he saw the animals or not, can he describe further, and basically what if, let's say, he was bitten by something, what are the measures or first aid that been taken, and then whether the patient is actually having went to the GP or nearest clinic or local nearest clinic for treatment or not. And I think that's about it lah for the history of the presenting illness. Yeah, as a start. Thank you.
All right, thank you, Dr. Sabrina. So to answer Dr. Sabrina's question, this case was referred to RIGHTS, and there is a post-consultation further questions by RIGHTS to the treating doctor. All right, so the first question, what time patient woke up before patient went to the hospital? So it was 6 a.m. in the morning, so it has been already about more than 24 hours after patient came to the hospital. And where was the patient sleeping? Because in view of there might be bitten by something. So this patient slept on his bed at home with 1 meter height from the floor. And is there any pain that woke him up from sleeping? So the patient was unsure about that, but noticed the wound a day before and went to the hospital at 6 a.m. And the pain worsened, and there is a redness since 7 a.m. on the day patient went to the hospital. So is there anybody staying with the patient? So yes, it is. That is with the family, extended family members because of Hari Gawa celebrations. And what was done or what was taken before the patient going to the hospital? So patient did squeeze the wound prior going to the hospitals and noticed a seropurulent discharge coming out from it. So Hari Gawa celebration in which the family members gather at home to celebrate Hari Gawa. During the celebration, they also did drink air tua, if I'm not mistaken, in which this patient might fall into a state of drunk, and he was also unsure about what happened to him throughout, because throughout the day as he might be in a state of drunk. So we are not sure whether this wound has been there for a past few days or not, as he was also unsure about his condition.
Maybe Dr. Anjana, Prof. Anjana, and Dr. Greg, if you have any questions, are you familiar with Hari Gawai or Gawai Day celebrated in the state of Sarawak, and in Sabah they call it Hari Keamatan. So it's like Christmas. Yeah. Merry Christmas anyway, Anjana.
Merry Christmas, Professor Khalden.
Curious, what his occupation is?
All right. So regarding the occupation, I'm so sorry because we don't have any information regarding patient's occupation.
So, was this patient from a forested area or like a rural area, or is it in an urban, semi-urban area?
Patient, he lives in a rural area.
Rural area.
So the patient celebrated Hari Gawai, and did he sort of like confirmed that he was under influence of alcohol for few days before he noticed the injury to the or the problems to the leg?
All right, to answer that question, I would like to proceed with the examinations in
Oh,
emergency
okay.
department. All right.
Okay.
So in emergency department, the GCS score was is 15, and he's not septic looking with good pulse volume, and the CRT was less than 2 seconds, and the blood pressure was normal. Heart rate was mildly tachycardic at 102 beats per minute with the respiratory rate of 20, and the temperature was febrile. And abdominal examination was done. It's soft and non-tender. Lungs examination was clear, and the cardiovascular examination was normal, dual rhythm and normal murmur. And we also checked for the lower limb examinations. So that it is found that there's a 3-bite wound over the right mid shin, anterior aspect with necrosis, and there's also erythematous area about 3 by 5 centimeter, warm to touch, and there was no pus discharge upon milking. And the CRT is less than 2 seconds. The DPA is palpable, and full RM of toes, foot, and knee, and no calf tenderness. And lymph node is also examined. It is found that there is a right inguinal lymph node swelling, 5 by 3 centimeter, standard, firm, and non-mobile. So see the pictures of the leg, the lower limb. So there is the 3-bite wound that is found at the right mid shin anterior aspect with necrosis. So there was no pus discharge for milking as well. So upon consultation with the right surgeons, there is a question arise, was it an old wound as it already has a scab over it? So the patient claimed that there was no wound previously, however, he was drunk over the weekend. So from this point of time, is there any discussions by the panelists regarding
Yeah,
this?
can we see the picture again of the leg?
So this is the picture of the
Yeah. Okay. Anybody like to comment? What do you think? Is this an animal bite or not, or self-inflicted wound?
Yes.
Can we zoom?
For me, it looks like yeah. For me, it looks like because there are three the odd or the weird three wound over there. What I can see from here is that probably the wound at the center has some form of dermal necrosis over there. But for it to be days, if let's say the patient was bitten by, for example, the snakes from the cobra species or anything, we expect the more necrosis would be, I mean, further increase. And furthermore, it seems like the area of actually inflammation has already sets in. So basically, yeah, it's quite atypical for us to get the 3 puncture marks. Yeah.
Yeah. Can we zoom in the middle picture? Yeah. I think maybe the 3 punctures that we see there, maybe one is probably an old one, whereas the 2 left and the middle one is maybe the more acute one. The one on top, the white with the white kind of already fibrous. Yeah, that one looks a bit like fibrotic tissue rather than the acute injury. What do you think? And if from my experience, I think is if you, let's say you look at it as a puncture from a snake bite, it's very difficult to see whether this is from a cobra or is it from a pit viper. Yeah. So Anjana, maybe what is your experience just looking at the wound?
Yeah, just looking at the wound, I thought, yeah, snake bite, especially looking at the location, mid shin, like can be a cobra bite, but then it's not certainly not the typical appearance. And also, what we have seen in our part of the world is some insect bite, like stick bites, can appear like that couple of days later. So that's the other thing that I'm thinking of.
So tick bites, right? Tick bites.
Yes,
But
yes.
yeah, it looks quite big, and he has some loss of skin there
Skin,
on the middle one.
yeah, especially the like two weeks, 1 week, 1.5 weeks, or 1 week later,
Yeah,
probably they
but
leave with a scar.
Hmm.
So with regard to the history, I'm not quite sure how long it has been because the patient was not aware.
Yeah.
But certainly not after 2 days.
Yeah, it's too acute, right? Probably surrounding cellulitis as well.
Yes.
Yeah. Okay. Anyway, it's very unconclusive to say whether this is a snake bite or not, but that certainly is in the picture. And I cannot see from patient's history that can corroborate from this injury to say whether it's definitive snake bite. Yeah. So what do you think, Greg?
Hello. Yeah, I think I heard the history. There was a history of 2 days pain prior to this presentation. Yeah, did I get it right?
Yeah, but he did not
2 days.
reveal what is the cause of that pain, right? How he got that pain.
Yeah. So it looks like an infection.
Suddenly woke up with the pain.
Yeah. Yeah.
Yeah, the night before.
It looks like some furuncle
Mm.
with ascending lymphangitis
Mm-mm.
occurring in the calf. I
Yeah.
wonder if he's diabetic. Undiagnosed diabetic.
That was not revealed. I don't think so. He's a young man, anyway. Yeah. So, okay, maybe our moderators can highlight us, maybe lighten us a little bit more.
All right, so we proceed with investigations. So blood was taken and was sent for full blood count, electrolyte, renal profile, as well as the other blood investigations. The HB was normal with the blood cell count was mildly elevated, and the platelet is also normal. And the electrolyte normal, renal profile was normal. Creatine kinase was elevated, is elevated with coagulation profile normal. And X-ray was also done for this patient, shows no foreign body seen as well as no fracture seen in these patients. And to add on more investigations, ECG was done, shows frequent PVC on investigations. And so regarding the investigation, is there any comment or discussion by the panelists before we move on to the management?
Yeah, that's up. Anything? What do you think? There is some inflammatory process there, right? That's
Yeah, definitely. And the CK is actually raised. We are not sure when the patient was drunk, what happened, whether the patient is actually like fall down and injured himself anywhere else. And but the X-rays looks, I mean, fairly clear. Other than that, I just interested in the patient's social history a bit more, so that I can anticipate maybe the capillary blood sugar I cannot see over here. Maybe was not us. Yeah. So
yeah. So the WBC is not significantly raised, or is maybe on the borderline.
but the ECG is really interesting. I mean, yeah, 26 years old with this kind of ECGs. Of course, if let's say
Maybe in the
with
acute
the more
stage.
necrosis, with the more necrosis, typically of cobra, so we might actually think of whether it's actually like cobra bite or not. But this one is unlikely related to the bite. Yeah,
Or if there is
but
a
still need
bite.
to be investigated. But still
Yeah.
need to be investigated. Yeah.
Okay. The Prof. Angela, anything?
Were there any other interventions done in the before the hospital admissions? Anything?
Pre-hospital care.
Pre-hospital care, there was no measures taken by the patients. However, once the patient arrived in ED, there was a management or intervention done. So we move on to the next slide. So upon arrival, intramuscular tetanus injection was given for these patients, as well as IV tramadol and 1 pint of normal saline bolus. And patient was also put on snake bite chart, as well as the serial blood results every 4 to 6 hours. And patient was admitted and was given intravenous unison and PCM, as well as tramadol and neurovascular charting, as well as daily dressing for the wound.
So currently, what is the diagnosis that was established prior to admission to the hospital, prior to admission to the ward? Is there,
Prior to
what do you think?
admission,
What do you think? Should we diagnose this patient?
So I suppose I suppose this might be cellulitis arising from a furuncle in the shin. I'm not sure about the presence of a snake bite.
In our setting, this is more likely to be either scorpion sting or sometimes and also tick bites, as I used to say, because we get like this kind of appearance. And then third one would be a snake bite because we have a cobra. But I think it's more likely an insect bite leading to cellulitis rather than a snake bite.
Yeah, he has a bit of kidney, acute kidney failure. Is it? Is there a kidney failure? Is a creatinine a bit raised? The kidney. So maybe that could be related to the weekend binge. Alcohol can make you a bit dehydrated as well, and your liver might be, knock off, and your CK may be a bit raised. So that could be related to his weekend activities during the gawai. I think that's why maybe they want to observe that, and they do a repeat of
And
the blood during the observation. Yeah.
and there was some
So
a slight increase of serum creatine kinase, I guess, isn't it? Some
Yes,
evidence of
yes,
1,000 something.
yeah.
yeah.
1,000.
So well, that can be anything, right? It could be from the wound itself. The cellulitis can actually cause soft tissue, not specific cardiac marker. Since there is no associate with any specimen, what do you think, Dr. Sabrina? Should we document what's your diagnosis?
My diagnosis will be unidentified injury.
Unidentified cause of injury, yeah, okay. Because history is very undefinitive cause, right? It's just suddenly,
Yeah.
it can't pinpoint even. So we don't guess. You're right. So we just put as unidentified cause, and we treat symptomatically, I suppose. So at the moment, as Greg was saying, cellulitis is the most evident at the moment. So we just treat as whatever cause is for the cellulitis. So what's your standard course of management? So let's our moderator maybe highlight us a bit more.
for the management for this patient, in view of cellulitis before consultation with RICE, the diagnosis was cellulitis, so this patient was given antibiotics and as well as pain analgesia for pain management and neurovascular charting as well daily dressing. And post consultation with RICE, the diagnosis was changed into unidentified cause of injury.
Okay. So anything else? Any progress after that in the what? No.
No, there was no progress in the
Okay.
work.
So what do you think maybe that could be helpful for this patient for cellulitis? Let's say you want to treat it. What else can we ask for the investigation?
I think if we have if there's any like discharges that we can swap and send for CNS, it will be helpful for us to determine what are the exact organism if there's any, and we tailor the antibiotics then according to the CNS. I would like to explore more on his social history again and see whether the patient is actually is a IBDU or actually the drinking habits. And looking at the CK trend, probably with the PVC as well. This is a bit of our topic, but I would like to do a serial ECGs and probably taking one troponin I. And we have got bedside echo that we can look for any say vegetation, the function, and document it into the patient's cracking. Yeah.
It doesn't look like patient has some immunocompromised feature because the blood test doesn't really reflect on that, right? Patient responded quite normally towards the whatever the organism is. So maybe culture and blood culture may be helpful if we do that. Plus the swab CNS, because he said there was pus from the one of the wound. So I'm not sure if there was actually pus, because in the ED I think they said there was no pus. So maybe just a wound swab. That's also another way to try and see what the organism could be and treat accordingly. So I'm not sure about Singapore, but our culture takes about 3 days for something to come back. So usually they will review after 3 days. If there's no growth and so on, they just continue with a broad spectrum treat, sort of like empirically for the cellulitis. Yeah. So this patient was admitted or discharged, or how what's the progress?
We are so sorry, Prof. We have limited information regarding the progress of the
Okay.
patients either being admitted.
Okay. So I think stuck with the admission to the ward. That's it. We sort of lost the progress of this patient. So hopefully that they did the culture and treat accordingly. But it's at the moment I don't see. After 2 days, we if we are neuro, if it was a snake bite, we would have already see neuro symptoms very early. But if it is, like say, from a pit viper bite, from Malaysian context, we will see some derangement of the coagulation profile, but we don't in this patient, and that's why I think the serial blood test would probably confirm that finding. So after 2 days, maybe a bit delayed if to see any significant systemic envenomation from a pit viper, usually within the first 24 hours, if there's significant. And there was no significant swelling, right? There's no painful progressive swelling as well. As we can see, the RPP there
Yeah.
is not showing any. That's another thing. I'm not sure about in Sri Lanka, but in Malaysia, most of the time, if you have envenoming from cobra or from a pit viper species, there will be significant swelling, and the swelling is typically progressing proximally as well. So we don't see it in this patient. So that's why we are not sure. It may well be a snake bite, but the snake could be a non-significant venomous snake or non-venomous snake, and that may lead to introduction of the bacteria to the skin, and that's why we see a cellulitis feature of this patient. Yeah. But what do you think? Are you agree with that, or?
Yeah, I quite agree. Like in our setting also, about like 80% of the bites are caused by vipers plus cobra. So you have definitely the swelling, and that swelling compared to what we see in the picture, I think it's a completely different. Like when you get snake bite
Yeah.
swelling, you get the characteristic swelling. And also,
Yes.
usually some of the snakes, like in our setting, what we have is mainly hump nose vipers and cobras. They usually give rise to blistering as well around the
Yes.
bite site.
Yeah.
And patient, when you and usually patients are quite aware when they are bitten. So, patients who are
This one is a bit
unknowingly
exceptional. He was having fun.
patients unknowingly getting bitten is quite rare. So I guess that kind of bites are mainly shifting towards
Yeah.
crate bites.
Yeah.
So yeah,
This could happen, right? People just can't recall because, yeah. So I mean, just I think we think that snake bite or whatever animal bite is straightforward, but presenting like this, patient like this, can be very tricky.
All right. Before we proceed with the second case, is there any more additional by the panelists, or we can proceed with Q&A session for case one?
I have a
Okay.
general question. Sorry. I have a general question. Would a
Okay.
snake bite somebody in their sleep?
Yeah, yeah. That's a very good question, because we have a lot of cases where patient woken up with a stinging sensation on their body while they're sleeping, and then woke up and it's typically dark. They couldn't see anything, or sometimes they sleep during the daytime on the floor on the sofa, on the carpet, in the living room, not necessarily in the bedroom. And they were woken up with a a stinging sensation, and they just cannot see what the animals are, the animals that may bite them. Some may see a mouse running away from them, and they think that they were bitten by mouse. This one, Dr. Sabrina has a very good experience. Patient adamantly saying, "I've been bitten by a mice because I saw the mice running away from me." But what the presentation were very typical of a cobra bite. So where does this fit into the story? So it was actually the mice was running away from the snake actually, and the patient got caught in between, in the middle of the escapee mouse. So yeah, but the patient blamed the mouse rather than the snake, which he did not see. Yeah. So, but the physical symptom and so on is typical from a cobra. As Anjana said, there could be a dermonecrosis, and pain, swelling, and even blister developing later on, with some neuro symptoms if it goes systemically, right? So yeah. So in Malaysia, yes, I'm not sure about Singapore, but Singapore maybe you don't have people sleeping on the floor, maybe, and maybe many are on the high rise. So in Malaysia, many houses are still on the ground level, so they are quite close to where the snakes could enter the house and enter the house through the whatever holes that they can find, and yeah. Yes, that's one of the issues that we see in Malaysia. It's not just sleeping and people going out of the car, entering the car, so they still got bitten also on their foot. It's very difficult to see as well. So we have those incidences. Yeah, and it's not just adults. We have babies bitten on the head. Woken up crying, and the parents goes into the room and there's a cobra on top of the head, standing up. So we had those type of cases as well. We had a past history of people using snakes to do harm to others, and they just throw the snake under the blanket, and then the person goes in and they could, this is malice. So yeah, I'm not sure about Sri Lanka, but we had a few story from India. People uses venomous snake to commit crimes in order to maybe claim insurance and so on. Yeah.
Yeah, in Sri Lanka, we have a classic case. We get this crate bites. We get quite a lot of constant crate bites. So people, when they sleep on the floor, in especially farmhouses, during the monsoon season, we get quite a lot of crate bites, and usually the bite is painless, but the bite sites are in weird places like back of the ear, on the scalp and all. That's very difficult to find out the exact bite site, but they usually present with neurotoxic symptoms.
They will present quite early, right? If it's a crate bite.
Yeah. They would present quite early, but there are rare cases where patients sometimes take few hours to come, especially in cases where they are in rural farmlands. And one problem in that case is that because of the pain there's less pain at the bite side, they sometimes neglect can continue to sleep if they have not seen a snake, and then for a couple of hours later wake up with abdominal pain and blood, and then then they present to the hospital.
Okay. Yeah. So Singapore is, a bit more high rise, so quite safe. Nobody's sleeping on the floor. Yeah. But anyway, that's a good point, because one of the preventive measures, because of people still sleeping on the floor and on the ground and so on, that's where the prevention using mosquito nets. Am I right, Anjana? Mosquito nets is used as a protection against snake bites if you are sleeping on the floor. So it's not just protecting from mosquitoes in terms of dengue fever or malaria, but you protect from snake bite as well for indication for mosquito nets. That's quite interesting. So this was actually in the WHO guideline, the recent one, 2016.
Yes.
Yeah. Okay. All right. So can we move on to the second case? Thank you so much. It's very interesting discussion. I think undifferentiated case like this is always interesting. Yeah.
All right. Thank you, professors and doctors. So before we moved on to the next case, we received 4 questions, and there is 2 questions related to the first case. So the first question, in this case, any early management or home remedies that the patient can do as first aid? So I open to the panelists to answer the question.
I think if let's say it is acute bite or acute sting, and particularly if we know what animal, or actually we saw the patient saw what had actually bitten him. So a few first aids that we can do, for example, in a snake bite, right? In a snake bite. So what the patient can do is the right thing, RIGHT. Just rest the upper limb or lower limb, immobilize, and get to the hospital as soon as possible. Nowadays, everybody is actually having some sort of smartphone with the camera capability. If let's say first of all, do no harm, and then make sure ourselves is also like safe. So if we can actually snap a few pictures of the culprit, so we can snap a few pictures, because it will be really helpful if the patient comes to the hospital and telling the doctors what actually happened, which animal is the culprit, because it will be evidence for the patient and can help in the patient's management as well. It doesn't mean that actually if the patient is really like very bad, or the patient is unstable, perlu ada juga gambar, so no need. But actually, yeah, that is something that the patient or the relative can help us with. So do it right is the mnemonics.
So what
That
what
is what.
about let's say this case? Do we say that patient is okay for patient to wash the wound? What
Yeah,
do
you
you
can.
think?
In Malaysia, we can wash the wound. So, if let's say the wound is very dirty, so you can actually wash with clean water. But let's say if the patient is having a very large laceration wound due to like python bite, so with spurting bloods all around, so it's a bit difficult, right? So control the bleeding first, and then stop the bleeding, control the bleeding, put a gauze, and then compression bandage, go to the hospital as soon as possible. But if let's say it is about bites, so you can actually clean the wound. If let's say being sprayed by the venom to the eyes, so what we can do is that we can actually irrigate the both eyes or only one eye, the one that actually being sprayed. So as you all know, all the medical students got one snake that can bite, which is our Najah Sumatrana or spitting cobra. So it can bite. So the first aid is the apa ni irrigating the eyes with lots of
Spray venom.
water before coming to the hospital. Yeah.
Yeah. I think it's the same in Singapore. I think they have a Najah Sumatrana as well, so which can spray venom to the eye.
Yeah.
I think it's in Sri Lanka. Is there a spitting cobra?
So
Or
in Sri Lanka, we don't have spitting cobras. We have only one species, that is Naya.
yeah,
So again, like as what is practiced in Malaysia, we also basically advise the patient to wash the bite site, and then with a clean water and soap, and then we basically advise against application of any tourniquet or any compression bandage because of the harmful, because most of our bites are causing swelling and the risk of compartment syndrome. So we advise against, and then bring the patient as soon as possible. That's what we.
yeah. We don't want them to waste time, right? So even then, the washing needs to be careful as well, because we don't want to be too vigorous washing, and that actually spread venom as well. So you have to be mindful what we advise patient to do. So it's just maybe just um, irrigate the wound. No need to have excessive massage of the wound. Cover with a clean cloth. As you can see just now, the leg is quite exposed, quite raw looking. So we just cover with clean cloth and then just bring to the hospital. Yeah.
Yeah. So as you said, sometimes patient try to squeeze
Ah,
out the
yeah.
blood, thinking that the venom
Yeah.
will go out.
That will only make things worse. Yeah. Okay. Yeah. No sucking as well. Yes.
Yes.
Okay. Do we have any more questions?
No problem. We can proceed with the next case.
Okay, next case.
Okay, so we'll proceed with case 2. So for the history of presenting illness, a 29-year-old female referred from Clinic Kesihatan alleged spider bite at 6 a.m. in the morning. She sustained minimal bruise, pain, numbness, and tingling sensation over right little finger and thumb. There's no fever, no chest pain, no other neurological symptoms, and the vital signs is stable. So I would like to open the floor for discussion to all panelists.
Yeah, maybe you can tell us what is Klinik Kesehatan.
It's a
Are we
community clinic where the patient will go.
It's a government clinic, right? It's a government
Yes.
clinic. So it's like a GP, but meant for the public, right? Okay. So any comments? Anything? What do you think? Can see the wound? Very. Yeah.
So
Is there a puncture wound? You zoom it a bit.
Little finger, and thumb.
Okay. Little finger or index finger?
Index.
Index.
so the time of bite to the presentation, what was the time gap?
You bitten at 6 a.m. When did patient go to the clinic?
Well,
How many hours?
The patient arrived at the clinic around 10 a.m. in the morning.
About 4 hours. So what did she do within that 4 hours?
So we're moving on to the next slide. So before the presentation to the ED, she was sleeping in her bed. Suddenly, she felt pain at the thumb and little finger area. Then she saw a spider at her hand. She washed her hand with tap water before going to the clinic.
Yeah, so Greg, your wish came true. So another case on the bed. This time you have the offending thing. So definitely not a mite or so, so it's a spider. Now we're going to the spider. So
Seems dangerous to go to sleep.
yeah. Not on the ground.
Yeah, it's unusual. The thumb and little finger.
Yeah, so it's like a pincer grip, right? It's a pincer kind of injury. So the story again doesn't corroborate with the injury kind of feature. So what do you think happened? Maybe she was trying to grab the animal or something and then create a
Possible.
story. Yeah. So this is the thing that we see. A patient present with history like this, and then we see that the injury doesn't reflect the story that was given. So we tend to question. So, but unfortunately, we don't know. Only God knows what happened. So we tend to take a patient's account with a bucket of salt. you know, so you just have to bear in mind and then have that kind of a suspicious mind to treat this patient. So anyway, so this is already like more than 4 hours, right, after incident. So any other features of the patient complaint besides pain? What was the pain score?
Sorry, doctor, we didn't have any information on this.
Okay, so what else that you have for us?
Okay, so for additional information that we have is her last tetanus toxoid received at 2018 due to the fall and abrasion wound. And the management have been done is we just treat the patient symptomatically. There's no antivenom was given and no special blood test done. And we observe the progress for 24 hours.
So, yeah, Anjana, you want to ask anything else?
So,
Greg?
there was no any other local features like piloerection or any other muscle spasms in the said limb or anything? Nothing like
Local
that?
sweating. Local sweating.
Yes, yeah.
Yeah, okay. I know where you're thinking. I know where you're going with that. Okay. So no other local features, right? No other local complaint.
Yes, there's no.
Okay. So observe progress for 24 hours. No special blood tests. So treat symptomatically. So yeah. Greg, anything? You satisfied with the management here? Singapore got spider bite?
Very seldom. None of them are. I mean, they're not significant to humans.
Yeah.
Yeah. So probably nothing much needs to be done except analgesia, maybe.
Yeah. So the question is, what spider, right? She said she had the spider.
Yeah.
So maybe our panelists can identify our species. Do we have a pictures?
Yes, we have pictures from the patient.
The patient brought the spider. Ah,
Yes.
okay.
So this is the spider.
Is it brown widow?
No,
Brown.
it's too big for a brown widow. This is a yeah.
Yeah.
Tarantula.
Tarantula. Tarantula.
So it's a tarantula. So Malaysia do have tarantulas, and we have big ones like this. This is a bit about maybe a size of your 3 fingers width and length, and because of the size, they can pack a punch when they bite. But the venom is known to be harmless to human. We don't get typical necrosis, or some people go into renal failure or other systemic symptoms. The thing that we worry about some of the stories of tarantula is the hairs, right? The hairs on the body. Some tarantulas defensively will spray out this sort of like sharp hairs, and it can get into your eyes, into the skin, cause irritation. So so far we don't have those species of tarantulas. So just that these ones are incidentally maybe come into contact. As you see just now, patient was on the floor, or lying down on the ground, and that's unfortunate. Sometimes they just come close, and somebody turn around and crush it or so and injure it, and it defensively bite. But then the bite on the finger is, I don't know why, doesn't look like accidental to me. It could be what we call defensive from being picked up or something like that. So anyway, we have a lot of cases. Not a lot, I would say. It's not uncommon in Malaysia for tarantula bites, and there are many species of tarantula. And the unfortunate thing is that we cannot identify the species just from this picture.
By the skin.
Yeah. So we don't, because there are certain identification feature that we have to have from the physical of the appearance or appearance of the tarantula, the pedipalps. You turn it around, you can see whether it's a male or female, and then you can look at the size of the what we call um, the organ, that's the spinnerets, the part of the body. So those things cannot be seen here in this picture. Even the genus here, Theraposidae, is just a guesswork based on very poor image quality here. But it is a megalomorph, so it's not a true spider. It's not an araneomorph. So it's a megalomorph, a tarantula. So the other group is the araneomorph which is the true spider. And the difference between these two groups mainly is maybe the size, the features of the body, and also particularly the what you call that? The uh, the fangs. So Megalomorph, the fangs is like this, if not mistaken, and Araneomorph is like this. Okay, so yeah. So maybe that's how she got the two punctures on the thumb and finger, because the Megalomorph is the fang is like that. So if it is like that, biting, so it could be from the same finger, left and right. Okay, all right. Interesting. There's nothing much to discuss about. You just observe the patient, treat symptomatically, I think. Yeah. So no big spider in Singapore as well. Huh? Yeah, you're missing the fun. Anyway, any dangerous spiders in Sri Lanka?
So we have only tarantulas. We don't have the other group. So basically, we have 10 species of tarantula, and they're
Okay. Yeah, we
pretty
have
large
about the
one.
same.
Yeah,
Yeah,
we get
we have a bit more.
frequent. Yes, so we get frequent, not very frequent, but somewhat frequent bites, and then and I have seen cases of where patients develop piloerection and also some myochemic so rhythmical muscle movements in the limb.
Okay.
That is transient and pain as well, but well, usually they don't last beyond 1 day. So patients are quite okay after 1 day. That's
Yeah,
what we
you
have
talk
seen.
about erection and so on. So you're looking at the Latrodectus kind of a group of spiders, right?
Yes,
So
yes,
we don't have the red the black widow,
black day.
but we have the brown widow. I'm sure you have also the
Yeah,
Latrodectus,
yeah, yeah.
yeah, a brown
And
widow
actually,
spiders.
we
Yeah.
have a couple of species in Sri Lanka, but no reported bites. Yeah.
Yeah, we encountered a few bites and we published the two cases, very interesting cases of the brown widow bite, which is confirmed because we have the specimen, and the specimen was making the nest in the motorcycle helmet. So
Oh,
patient left the motorcycle helmet not used for a couple of days, and he was they put them on after a few days and not checking what's inside the helmet, and they got bitten on the ears and on behind the back of the ears. So they complain quite severe pain, and these are not really too big spiders. These are rather small spiders. So again, they bite defensively. They don't chase after human. So it is a nice two sample of cases that we have. It's not very common, but we do have brown widow spiders, and we only see pain as the main problem of the bite. No piloerection, no loss of neurological function. Anyway, and these two cases are published, so you can have a look later. Okay, all right. So thank you. So we move on. Any questions? Any other questions? Maybe for these cases.
Yes, doctor, we have questions from participant. So if the patient did not notice the spider, what kind of complication should we worry about? And how early should she seek for treatment?
Dr. Sap?
Sorry, come again? What was the question? Sorry.
If the patient did not notice the spider, what kind of complication should we worry about? And how early should she seek for treatment?
Okay, so if let's say the patient did not notice what are the animal that bitten him, but he confirmed that probably it is an unknown animal, but they are unknown, so we manage the patient as unidentified animal bite, and usually the patient need to come to any of the health care facility and anticipate the worst. I mean, the assessment will be the same. Assess whether first of all make sure there's no danger, patient is responsive obviously, because the patient can come to the hospital, right? And then no need to shout for help because the condition is stable, that the patient can come, and then stabilize the airway, breathing, circulation, disability, and then ask regarding the focused targeted history and clinical examination. And after that, only focus on the history tu and the mechanism of injury. And then I think we should anticipate the worst because in any unidentified animal bite, we have to like monitor as a syndrome. Worst case scenario is snake related injuries kan macam snake bite. So probably you need to admit the patient either to your observation ward in emergency department or to the ward for observation. And observation is based on the syndromes lah. Mm.
Great. You want to add on?
No, generally agree lah.
Let's say you got the spider bite now in Singapore. How would you approach it?
Well, I think the first thing would be to address the symptoms. I think most of the time, it is a local envenoming. Very rarely is there any systemic envenoming. But the symptoms of envenoming, if they are systemic, it may be delayed lah. So sometimes if the patient is well, they can be discharged first and then reviewed in 24 to 48 hours or so.
Yeah.
Yeah.
So
But the
we
question-
yeah. Go ahead, Sab.
Because the question is asking if let's say we don't know that this is what kind of animal, so maybe that is the approach. If we know that the one that bitten is actually the spider, so we can follow the the flow symptomatic treatment and all that.
Well, this definitely not Latrodactylus or even brown or reclusa spider. We are not that worried about local necrosis and so on. So it's more again, as you said, EBCDE of emergency care, treat the symptom, symptomatically. Pain is the issue, so analgesia may help based on the pain score. And there's one question here: what is the treatment if patient develops symptom after observing for 24 hours? So if you are actually observing the patient already, so patient develops, so you continue observing and treat symptomatically as well until patient is better, and before you decide to discharge the patient lah. Or if you do discharge, if you did discharge the patient and then patient develops symptoms at home, hopefully when you discharge, you did tell the patient that please come back as soon as possible if the issue gets worse, right? So that's the most important thing that we can advise patient, not to mask themselves with unnecessary analgesia and so on. So that is another issue that we see in Malaysia. The doctor discharged the patient, discharged with analgesia. Patient did not have any pain or whatever at the time, but they discharged with analgesia. So patient, without telling them please come back, so patient thought if just pain, just analgesia, so that will mask the problem, and you miss the opportunity to observe. And if things get probably worse, then you might waste time from getting patient to come to the hospital as soon as possible. Just because patient masks themselves with analgesia, it's not treating the problem, right? Analgesia is not treating the envenoming problem. It's treating the pain, and not even treating, is masking the pain. Yeah. So if let's say patient develop neurotoxicity or even some other problems, then the patient will be outside of the hospital and it's going to be time wasting because of the masking of pain. Anyway, yeah. So always ask patient to come back as soon as possible. So in Malaysia, we have already sort of like be cautious about giving analgesia when discharging patient. So at the most of the time, people automatically will discharge with analgesia. I don't know why, even though patient doesn't have pain. So that's a waste of resource as well. So we said if there is pain, please come back to the hospital, and that is hoping that that will be the trigger for patient to come and seek help early, rather than give analgesia and wait for whatever time outside. Yeah. Okay. Next question. Next, any other question, or so there is?
I have a question for the panel.
Okay, okay.
I won't be answering. So, Prof, you mentioned about brown widow spider that you
Yeah.
published. Is it the same as a brown recluse spider?
No, different.
Mm.
It's a Latrodactys genus with the black widow, or in Australia you call it the redbacks. And this has spread quite a lot around the world, including to Japan, through exportation. In Malaysia, I'm sure there is possibly, but we have not encountered yet. And what we do have indigenously, and probably from trade as well, from east and west, right? India, Sri Lanka coming to Malaysia, and then China and so on. So we do have brown widows spiders. The recluse spider most likely we also have, but we don't have anybody yet confirmed to be bitten by the brown recluse. This is the one that can cause local tissue necrosis. Quite a harrowing kind of feature, because it continues to lyse the cell if it got bitten locally. It may look small, but eventually it become bigger and bigger and bigger. It's not like going to heal well. So we don't have a case like that yet in Malaysia. I'm not sure if there is a brown recluse, the recluse spider. The way we identify is the violin shape kind of mark on the body. So violin, violin. Yeah. So it looks like that on the body. Yeah. Sri Lanka has brown recluse. Has the recluse?
I'm not quite sure because definitely
Mm.
we didn't have any cases.
Uh,
So I'm not quite sure. There are a large number of other species as well, and even the redback. Sorry, this black widow family. There are a couple of species as well in Sri Lanka, but no cases. Yeah.
okay. Right. So we pray for some cases. At least we can publish. Okay. Right. So yeah. Any more questions? Any other question? So there's some question about antivenom. Is it? But this is snake bite. Okay. Or maybe we can answer at the end. So next, maybe we can do this next case, moderators.
All right, so now let's proceed with the next case. So for this case, we have a 55 years old male with no known medical illness, and this patient has been working as a fisherman for the past 20 years. So while he was fishing, he tried to pull out the net vigorously, and the net snapped, and a jellyfish flew over the net and fell into his right eye, and his right eye got stung by the jellyfish. So the characteristic of the jellyfish by the patient, he described that it is orange in color and has a short tentacles at the corner of the body of the jellyfish. So post-incident, patient presented with a pain over right eye with the immediate onset, and that it is also associated with red eye as well as watery discharge with a pain score of 8/10. And then before patient went to the emergency department, he rubbed his right eye, and washed it multiple times with water, and no medication or vinegar spray was applied. So I'll open to the panelists to discuss on this case before we proceed with the examination.
Do you have jellyfish in Sri Lanka?
Yes, we have, but very rarely we get reported stings. We have box jellyfish and the other one, the Portuguese man of war,
Yeah.
both, but stings maybe like 2-3 reported ones, nothing else.
Okay. Yeah. So this is I think quite a unique feature of injury here. Typically, the sting from jellyfish is on your skin, right? On your hand, your limb, or your body. But this one is into the eye, so it's like very rare kind of incident. So what is there any danger that we should be considering here? Uh, you know, uh, if we have vinegar, are we going to pour vinegar into the eye? So that those are kind of I think the questions that comes about when we look at this history. Greg, you want to what do you think? Is there any issues there that we have to look for?
Looks very challenging.
Yeah, it looks very challenging, isn't it?
Yeah. So I wonder if the tentacles are around the eye or the conjunctiva.
Yeah.
So if there is need to remove it first. No?
Yeah, okay. So if there is a, you mean there is a, if there is a physical tentacle still stuck on the eye, we remove it. Yeah, okay, that kind of logical thing to do. Okay. So
Yeah.
what else are we looking at here?
So I
So
think
quite severe pain, right? Quite severe pain.
it's
What
possible.
about the species here? Do you think it's a box jellyfish? Orange color.
So it might not be a box jellyfish,
Yeah.
typical one. It may be of a Saura species. Maybe. I'm not sure.
Yeah. Chinese
Um,
Chrysaora chinensis. Okay.
yeah.
So interesting to know also the location, right? Where is the
Yes.
location of the incident? Is it which state? Do you know? Which part of the ocean? It says here he was fishing
Laka, Prof.
in Malacca.
Mhm.
Okay, so in the Straits of Malacca. Yeah, so Malacca we share with Singapore as well. So most likely you will have the species as well. The orange color jellyfish, well, if a box jellyfish, typically it's it's almost translucent, right? For the box
Mm.
jellyfish, but it's jellyfish bell is with color. We see that most of the Chrysaora, you're right, are orangey in color. Not too orange, but orangey in color or reddish color. Other name is called the ribbon jellyfish with long tentacles, and quite a lot actually around Penang as well. It's quite common jellyfish to be found. So anyway, so he got injured to the eye. Any particular thing that we are worried about? So that's what we want to discuss maybe. So he did not apply any vinegar. He just washed the right eye with water. So is it advisable to wash with water or seawater? So or fresh water or seawater? That's another thing, right? That we were considering. So in this case, yeah, what do you think? Do you prefer seawater or fresh water, or doesn't matter?
I mean, if we are actually like going to the beaches and actually like swimming, if let's say the I mean the it enters our eyes. I mean, the seawater enters our eyes. Is not really a convicting lah. So basically, the patient himself actually thought that by rinsing the eyes with plain water might help, but probably it is not as he might think. So in this
Mhm.
case, of course, the advice of actually giving vinegar also will not be an appropriate advice, because if let's say we want to rinse the eye, so it's really like macam tak betul lah, because vinegar is actually acetic acid. If let's say the patient being stung elsewhere, let's say at the upper limbs or lower limbs at the body, so we can actually put the vinegar. Of course, the patient is in pain. So, let's say if the patient comes to the emergency department, what we can do to help is actually, um, probably if we have got the topical analgesia, we can actually apply the topical analgesia and giving the patient analgesic, whether oral or IV as well. Yeah, that is for
I,
me
will- I
lah.
will I will agree with that one. Yeah. So actually, seawater is not that painful to the eye. Have you tried opening your eyes when swimming in the sea? It's actually it's like saline, right? So it's not too painful. It
Still.
can be, yeah, it can be, yeah. So, but I think washing with rinsing with water, just plain water is okay because there's no big tentacles there. Which can discharge more. So I think it's okay. But what's in the eye, so that's the thing that we have to think about next. How do we investigate this further? So maybe our moderators can update us. What is the things that we should be looking at next?
All right, so now let's move on to the examination that has been done to this patient. For general examination, the patient came with GCS full, and the pupils are 3/3 reactive with a good pulse volume with CRT and less than 2 seconds. So the The vital signs were all normal, but the heart rate is mildly bradycardic with a 55 beats per minute. And the temperature is febrile with SpO2 of 98% of 100 room air. With the right eye examination, the conjunctival appear injected with chemosis nasally, as you can see over there. And the visual acuity on the right eye is 6/24, meanwhile for the left eye is 6/18 with no RAPD. So management done for this patient in ED. So topical alkene eye drop 0.5% was given, and vinegar soaked cotton balls was also used and draped around externally over the right eye. And also this patient being given lignocaine 10% over external right eye. And with that management being done to the patient, the PIN score improved from 8/10 to 6/10. So now proceed with the investigation for this patient. Blood investigation was done, showing normal blood investigation with electrolyte normal, saline profile also normal, with the creatine kinase also normal. So for this patient, he was referred to ophthalmology clinic for further assessment. And we see the picture first. So this, once the patient was referred to ophthalmology clinic, slit lamp was done for this patient. So any comment from the panelists regarding this picture?
Also. Sekejap the patient is how many years old again? 50 something, right?
Yes, 55 years old.
Yeah.
So it's quite interesting imprint of the nematocyst on the cornea, right? So this could be corneal ulceration.
Yeah.
The staining is positive, right? Is it staining positive?
I think there
So
was no
cornea is
staining.
injured already. So
The
but then
corneal ulceration.
circle. It's like kind of a circle arrangement of the stinging cells. So it could be a cluster of stinging cells arranged in circles on the tentacle. So they kind of imprint onto the cornea. So this feature also we see sometimes on the skin. We see maybe what we call punctate kind of feature on the skin. It's like, but it is arranged, it's like a dot, it's like a polka dot on the skin. Sometimes we see. So this is another feature that we see sometimes on jellyfish, small box jellyfish, the Caronex as well, which has the stinging cells not just on tentacles, but also on the bell. So the tentacle, yes, maybe a one linear line of stinging, but if it's on the bell, then maybe it's a wider, like, white big spot. So this is quite interesting. Not many cases was stung in the eye. So what is our worry here? Anjana, what do you think?
Yeah, so then, I think corneal ulceration is the concern
Yeah,
here.
patient has already manipulated the eye washing,
Yeah,
so that is another worry as well. Is it
yeah.
going to? And patient is elderly, right? So elderly.
50 something.
50. Okay.
5 years old.
Okay, my age. So
So,
anyway, so that is an issue. Will he
so,
be like?
so the other thing is whether there are any other non-fired nematocysts in the
It's very
location, but yeah,
you don't see the tentacles there anymore. So whatever you see
yeah.
there is already imprinted there, and that's
Mm.
from the discharge of the nematocyst. So we're not worried about undischarged nematocyst. Okay.
Mm.
So I think the issue here is what do we do next? So you see that they already referred to ophthalmology. So typically they will follow up the patient. I think. I think. So
Yes.
yeah. Okay.
So for this patient, was referred to ophthalmic clinic and was given a few medications. There was Vigamox, atropine, nitritol, and artificial tears. And this patient also received a follow-up for under follow-up ophthalmic clinic.
Okay. So symptomatic, maybe also, I'm not sure about atropine. How does atropine help for this patient?
Dilating.
Yeah,
The
that's for observation, or is it? But it's BD, right? So that's treatment.
treatment.
It's not for fundal examination. Vigamox. What is Vigamox?
Vigamox is a moxifloxacin, so it's antibiotics.
So they cover with some topical antibiotics,
Yeah.
artificial. Matrixinol is, I think, a steroid. Is it?
Um. Yeah, it's a steroid
Oh,
eye drops.
steroid eye drops and atropine. So just to control inflammation, is that what it is? So and then just to see whether the vision is going to be affected or not. Will there be what we call, because it's cornea, so if it becomes fibrosed, then you might affect your vision. So that's another thing that we are worried about. Something the eye. This is kind of a similar situation when we get venom into the eye from snakes. So that's one primary injury, and then there's a secondary injury. The patient will rub the eye while washing, that can cause even worsening of the corneal ulceration. So obviously, infection will be in the picture. We do treat sometimes with topical antibiotics prophylactically if there is a corneal abrasion, and also some painkiller topical analgesia. Yeah. So, any other follow-up from the ophthalm or progress of this patient?
Regarding this case, we have limited information regarding progress of the patient in ophthalmic clinic.
Okay. So, similarly, as I said just now, we had a case of the tarantula, right? So, let's say the tarantula hairs goes into your eye, so you will get this type of corneal injury as well. So we have to look at under the slit lamp, and you can actually see the hairs embedded into the cornea. And some people said that you need to remove it. I'm not sure whether that will actually cause more harm or not, because when you pull these hairs, there's barb. So in the barb. So if you try to pull, it can actually cause bigger lacerations as it exits from the same where it comes in. So it's like the arrowhead, right? The arrowhead goes, you try to pull, it's going to cause more injury. That's why if you get arrowed, you just push the arrow through and through. It's very easier, maybe to heal from that type of injury. Yeah. Okay. Right. Interesting. Okay. Maybe we have time for questions. Answer. Is there questions that we can respond to?
So we have question regarding this case. So in this case, prior to presentation to ED, we're rubbing the eyes or rinsing with water or vinegar as a sedate or relieve the condition.
I think we mentioned earlier, right? It's not really advisable because it's going to cause more pain. We definitely do not put in lignocaine gel in the eye, but I think we have a lignocaine eye drops, so which we can use to minimize the pain, to control the pain. So other than that, irrigation, as I said just now, I don't see why we can't use just clean water to irrigate, because the tentacles or undischarged nematocyst is not there. So the damage is already done. So it's just a matter of trying to relieve die from other foreign bodies in the eye that could be introduced during the rubbing of the eye. Anyway, yeah. So yeah, I think that should be covered. So anyway, any other questions related or non-related?
There are a few other questions now related to this case. So I think it's related to the snake bite case just now. The
Okay.
questions, is there a window period where antivenom is only effective? And how many hours after the bite will the administration of antivenom work?
Quite interesting. Angela?
Sorry, I didn't hear the question clearly.
Question is there a window period where antivenom is only effective? And how many hours after the bite will the administration of antivenom work?
So is this regarding jellyfish?
No,
Regarding the
snake.
bite.
All right. Listen, yeah, yeah. So that's actually it's a bit of a debatable topic actually, um, uh, because there are many factors coming into play when we think of the envenoming syndromes. So things like, for example, neurotoxicity and coagulopathy. Uh, what we understand now is that the antivenoms are, I mean, they have very limited role in reversing the established effects. So it's more mainly towards prevention of further damage. So that is why we always say earlier the better, give the antivenom. But there's no time window that we can define that beyond this point antivenom is useless. Especially now, even for syndromes like, for example, myotoxicity, you might see the myotoxic features develop later on, several hours later. Maybe creatinine kinase goes up even like 10, 12 hours later. But what we understand is that is because of the pharmacokinetic pharmacodynamic mismatch. So the toxins have already entered a couple of hours later, and the irreversible damage has already begun. What we see results several hours later is just a kind of the end result. At that point, you can't do anything. So for that specific question, there's no specific answer. What we say is that earlier the better, but giving antivenom for a patient, like even 24 hours later or 48 hours later, you cannot rule out any you can't say that it's useless, because still there can be certain venom components, especially spread in lipid tissues, that may be slowly absorbing in. But in general, the answer is earlier the better, but you can't say after several hours or certain hours it's useless.
Yeah. Greg, you want to add on maybe?
No. I think anytime is a good time. The earlier, the better. You can
Yeah.
still rescue some of the uninvolved organs by giving antivenom.
Yeah. Sab, you want to add on about this timing of giving antivenom? We get questions quite often, right? People asking this because that reflect another area as well. How soon you
Yeah.
should go to hospital. So he say, if you say antivenom is only effective, so I don't have to go to hospital early. So yeah. So
The
what do you
reason
think?
I asked the question whether this is regarding the jellyfish was that that in Australia we have jellyfish antivenom,
Okay.
and then of course
In Malaysia too.
sorry.
In Malaysia too, we have
Yeah.
jellyfish
So
antivenom. Yeah.
in jellyfish, what I think the common understanding is that if a patient survives to receive antivenom, that means
Yeah.
he's not going to die anyway. so, so, so
Yeah.
that
Well,
was yeah.
yeah. So it's timing, right? So,
Yeah.
but the question is, when do we give? So some people just say, oh, just give. But I think what we have to bear in mind is, sometimes patients do not get any envenoming symptoms. So why do we need to give? So it's always comes to our close serial monitoring of the patient. First is the time when the patient arrives. We hope that everybody comes as soon as possible after incident without doing any manipulation or go to the what do you call traditional healers and so on. So they just come straight away, so we can monitor them. So that's the I think that's the emphasis that we need to tell our medical students, that clinical observation of patient's condition must be done serially and closely, and is very continuous. Meaning that you cannot just see the patient once and decide. You have to look at how things has progressed. Sometimes patient comes looks quite swollen and so on, but it's already 48 hours. Why do you want to without any progression? So it has been there like that for 48 hours, so there's no progression. So why should you be worried? What we worry about is acceleration of the progress, right? So that can tell us whether things are getting worse or not. So serial observation, obviously, to decide whether antivenom should be given or not, there's clear indications to give antivenom. And also, after giving antivenom, we need to justify that the antivenom works or not. So for that, you need to continue to closely monitor the patient. So it's not just like after giving antivenom, that's it. Okay, I can go sleep and go have a swim or whatever and leave the patient. No, we still need to continue observing the patient closely to see whether the antivenom that we give has actually reversed the signs and symptoms that patient have of envenoming. So, for example, the pain may reduce, the swelling may stop progressing in terms of the RPP, the rate of proximal progression is already in either static or actually in deceleration, or actually even the blood test. So, let's say you're given a case of pit viper bite causing coagulopathy. So, after 6 hours of giving antivenom, the coagulopathy should show some improvement of the INR, the PT, APTT. If there was a bleeding from the site of wound, the bleeding stops. So those are positive signs, clinical signs that you need to pick up as a medical student, as a junior doctors, when you're observing the patient. You cannot just leave the patient like that and for hours and hours without any close monitoring. So that's why if you look at our guideline, the Malaysian guideline, we have like hourly kind of progress. The first 24 hours is crucial in terms of monitoring the progress, both before giving antivenom, indication, and also post antivenom. Yeah, so that includes blood tests as well. So we practice as per the WHO guideline every 6 hours. After the antivenom, we give antivenom. We do repeated blood tests as well. Okay. Yeah, so I think that answers the question. There's no time limit, as Anjana said, but uh, it's per indicated. And for that matter, patient needs to come to hospital early so that we can monitor when this thing arises, right? Yeah. Okay. Any other questions? I think there was one more, right, about antivenom. Let's see.
Yes, Prof. So another question, I think this can be answered by Prof. Khaldun or Dr. Sabrina. Does all hospitals in Malaysia have antivenoms available, or is it more readily available in district hospitals or rural clinics as they are more prone to getting bitten?
I assume this is related to snake antivenom. Maybe Dr. Sab can tell us maybe about antivenom supply in Malaysia.
Okay, so I'm not sure actually the one who is asking is a medical officer or actually a medical student. But anyway, the structure in our Ministry of Health Malaysia, I can talk on behalf of the government hospital, is that when we talk about antidote or antivenom, we have got 3 level of storage lah. But antivenom is not to say is the exclusive to be stocked at only tertiary center. So I can safely say that actually our government hospital actually has the antivenom storage, but as you may or may not know, actually for Malaysia, we do not actually produce our own antivenom, but we are importing from Thailand and also from Australia. The one that we import from Australia is the sea snake antivenom, and the one that we are importing from Thailand is mainly the hematopolyvalent, neuropolyvalent, the green pit viper antivenom, and the Malayan pit viper antivenom. And also another two is that the Naja Kautia antivenom and also King Cobra antivenom. So basically we have got around six plus one, so 7 antivenom that we have, but not all of the hospital is actually stocking all those 6 or 7 antivenom. During these years, so the remote envenomation consultation services with regards to the 24-hour voluntary on call has come out with the data that we have. So from this data, we know that okay, in certain location, the cases that we have is much more of like say cobra or Malayan pit viper. So it can further help those hospital in that particular region to stock mainly what kind of antivenom. So the storage of the antivenom at certain hospital in certain region is actually based on what are the cases that they have. Yeah.
And
Anyway,
what about the jellyfish antivenom?
and yeah, anyway, with the storage of the antivenom and antidote, so we have got the pekeliding. So our pharmacist is well versed with the pekeliding. What are the things that should be stocked at the hospital? With regards to the jellyfish, so basically the antivenom currently is actually stocked at the Sabah state, particularly at the hospital Sandakan, Lahad Datu and Tawau. This is because the number of cases that they have seen over there is very high, particularly in pediatric population. For Peninsular Malaysia, so far, there are discussions on wanted to procure. Let's hope that in 2025, we can at least stock in one or two hospital at the coastal region, so that if there's any cases, then we can use it. But bear in mind, for antivenom to be worked, I mean, it should be given in a severe kind of cases and early. Yeah.
Yeah, and Likas Hospital also has actually Likas
Likas.
Hospital is the first one that stocked the jellyfish antivenom. Anyway, yeah. So depending on the hospital will know what type of snakes that they have most and what are the appropriate antivenom to stock. So that prevents wasting of resources as well. So that's why it's very important to do the hospitals to do inventory of the cases and how many actually needing antivenom from this. Okay, so I think that's answer. I think there's one question about roof beetle. I think that the second case or is it the first case was could be a roof beetle. I would say that injury to the shin doesn't look like a roof beetle. It's very different. Roof beetle is not venomous. It's actually causing skin irritation from the caustic pederine. Uh,
Dermatology.
yeah, so it's a kind of a different feature, and if it is sleeping and so on, most likely it will spread to other parts
Yeah.
as well. So it's not just concentrated on that two particular dots. So
And it has
it's
blistering as well, isn't it?
yeah, it can,
Yes.
yes. And if you touch somewhere else, that some other places will also can, if you touch that place, touch on your face will get that kind of a blisters as well from the pederine. Okay, right.
I think
So
the pederine the pederis the roof beetles nature of dermatitis is quite distinct. If let's
yeah,
say the roof beetles actually is let's say just crawling on our skin, so it can produce like linear markings that over the times can cause blisters and actually scarring, so that it can be really painful and itchy at times. And the other typical features is that if let's say the roof beetles is at our junction in between junction at the elbow, for example, or the antecubital fossa, and you flex it and you have the the
but
certain
the
kind of
mirror,
injuries. Yeah.
yes, mirroring theory.
Yeah.
With a jellyfish sting as well. So
Mm.
the tentacle, you get a mirror
Mm.
of the tentacles on the flexing part. Okay, so do we have time for another case?
Due to the time constraint, I think we
Okay.
need to stop here. So thank you
Okay.
everyone for the thoughts and questions, and thank you to all of our panelists for your inputs throughout this session. So to make it more interesting, let's move on to a Kahoot quiz session. For this session, we have prepared a special prize for the winner, and all participants are welcome to scan the QR code or key in the pin for Kahoot to play. So to not wait any longer, I will pass to Associate Professor Dr. Ahmad Khaldun to continue with the session.
Okay, so we've reached our 40, there's more than two-thirds, so let's start. So first question, food. Number 3, A184040. Number 2, 7467, the AS. And the champion, A173351. We don't know who you are. Please, the champion, please give your details to our organizers, yeah, so that we can give you the book on lensing or medical significance. All right, thank you.
Congratulations and well done everyone for the effort. And to the winner, kindly reach out to us so we can hand in your prize.
So before we end the season 4 episode 1 clinical toxinology, is it relevant for medical students webinar? I would love to invite Dr. Sabrina Safri to give a closing speech. Please welcome.
Okay, Assalamualaikum and a very good afternoon. So it is my pleasure to actually joining the UKM Faculty of Medicine today together with my guru, Professor Madya, Dr. Ahmad Khaldun Ismail, Dr. Gregory Cham, and also Prof. Anjana Silva. So I hope that you enjoy the session for today and learn about clinical toxinology in a interactive way or in a case discussion way, so that you know that actually it's not that kind of straightforward in managing the certain clinical toxinology cases. Yeah, so I hope it sparks your enthusiasm, your interest to learn more on the toxinology, besides other things in the emergency medicines that you can explore more, right? Okay, with that, thank you.
Thank you so much, Dr. Sabrina, for the speech.
As the saying goes, to every beginning, there's an ending, and now the webinar has come to its end. So as a reminder, please scan this QR code shown on the screen for feedback form and e-certificates. Once again, thank you everyone for gracing today's webinar with your presence. We truly appreciate it. On behalf of the organizing committees, we would like to apologize if we have made any mistakes throughout this session. Thank you.